Good morning everyone. Today we are discussing about most common and important topic headache under guidance of Dr. Manu Parmar sir, professor and head of department of psychiatry. There are two types of headache, primary headache and secondary headache. Primary headache has three types, tension headache, migraine headache and cluster headache. Secondary headache. Cause of secondary headache is environmental, infectious, vascular issue, trauma, neurological, medication and hormonal changes. Most common headache is a tension headache. Definition of tension headache. Tension headache are caused by muscle contraction in the head and neck region. Epidemiology of tension headache. A tension headache is the most common type of headache. The estimated global prevalence of active headache disorder is 52%. Among this, tension headache is 26%. Women had higher prevalence than men. Prevalence peaked in the 30 to 40 years. Now, risk factor of a tension headache is associated most commonly in smoking, during pregnancy, high percent in body fat. Clinical feature of headache: dull aching head pain, feeling of tightness or a pressure across the forehead or on the side of the back and head region. Tenderness in the scalp, neck and shoulder muscles. Classification of headache: infrequent episodic tension headache, frequent episodic tension headache and chronic tension headache. Now treatment of tension headache, pharmacological and non-pharmacological. First, pharmacological treatment: acute management, acetaminophen, ibuprofen, naproxen sodium, ketoprofen, diclofenac sodium. Then prophylactic management by amitriptyline and mirtazapine. Then non-pharmacological treatment: problem solving and stress coping, regulation of sleep, exercise and meals, cognitive behavioral therapy, relaxation technique, biofeedback, combination of the above. Now further topic is covered by my fellow colleagues.
Okay, cool.
Good morning everyone. Myself Hamza Khalak. I am with Dr. Manu Parmar sir. And the second most common type of headache is migraine.
Loudly.
Migraine is genetically influenced complex neurological disorder characterized by episode of moderate to severe headache, typically unilateral and frequently accompanied by nausea and heightened sensitivity to light and sound. Now, classification of migraine: migraine with aura, migraine without aura, chronic migraine and probable migraine. Now, migraine without aura. This subtype involves recurrent headache attack that lasting 4 to 72 hours. The pain is typically unilateral, pulsating in quality, moderate to severe in intensity, aggravated by physical activity and associated with nausea, light and sound sensitivity, phonophobia. Migraine with aura. This subtype features recurrent, fully reversible attacks lasting minutes, typically present with one or more unilateral symptoms such as visual, sensory, speech and language, motor, brainstem or retinal disturbances, usually followed by headache and other migraine symptoms. Chronic migraine. This is defined as headache that occurs on 15 or more days in a month for more than 3 months, with migraine features presenting on at least 8 or more days in a month. Now, probable migraine. This is symptomatic migraine attack that lacks one of the features required to fulfill the criteria for one of the above and does not meet the criteria for another type of headache. Now, epidemiology of migraine. Migraine is highly prevalent, affecting approximately 12% of the population, with annual rates reaching up to 17% among women and 6% among men. Among children, it is more prevalent in girls than boys. The prevalence of migraine increases during puberty, peaks between age 35 and 39, and tends to decrease later in life, particularly after menopause. Pathophysiology of migraine. It is mostly due to serotonin and calcitonin gene-related peptides. Symptoms. Prodromal symptoms. Common symptoms include yawning, mood changes, lethargy, neck stiffness, sensitivity to light and sound, restlessness, difficulty focusing vision, feeling cold, cravings, sweating, increased energy, thirst and edema. Now, aura. Changes in cortical function, blood circulation and neurovascular integration occurs in approximately 25% of cases. Aura can precede the headache or present it simultaneously. Aura are typically gradual, lasting less than 60 minutes. predominantly visual and encompasses positive and negative symptoms. Positive symptoms result from an active release by neurons in the CNS. Negative symptoms indicate lack or loss of function, such as reduced or lost vision, hearing, sensation, or movement. Additional changes in blood circulation and function of the brainstem, thalamus, hypothalamus, and cortex can occur. Now, postdromal symptoms. Persistent blood changes with symptoms after headache termination. This phase consists of movement, vulnerable pain in the exact location of the previous headache. Common symptoms include exhaustion, dizziness, difficulty concentrating, and euphoria. Now, prophylactic or preventive treatments. Indications for preventive treatment include frequent or long lasting headache, attacks causing significant disability and reduced quality of life, significant adverse effects from abortive therapies, risk of medication overuse, headache, menstrual migraine, hemiplegic migraine, brainstem aura migraine. Now, preventive treatment agents, beta blockers, metoprolol and propranolol, especially in hypertensive and non-smoking patients, antidepressants, anticonvulsants, calcium channel blockers, CGRP antagonists, and botulinum toxins. Acute or abortive treatment. Acute treatment aims to stop the progression of migraine headache, which must be treated quickly and with a large single medication dose. Now, NSAIDs, ibuprofen, naproxen, diclofenac, aspirin, acetaminophen. Now, sumatriptan, zolmitriptan, elatriptan, rizatriptan, elmotriptan. Now, selective serotonin receptor agonist, FDA approved oral lesmetidan tablets in October 2019 for acute migraine treatments in adults. Ergots, dexamethasone, transcutaneous supraorbital nerve stimulation, transcranial magnetic stimulation, non-painful remote elective neurostimulation, peripheral nerve blocking are the primary treatment. Alternative treatments include regular exercise, yoga, relaxation training, cognitive behavioral therapy, biofeedback reduction of triggers, detoxifications. Now, further topic will be covered by my colleague Jigar Jadhav.
Good morning. Myself is Jigar and I am with Dr. Manu Parmar sir, Head of HOD of Psychiatry. Another most common type of headache is cluster headache. Introduction. Cluster headache is the most common trigeminal autonomic cephalalgia characterized by the unilateral frequent debilitating attacks associated with the ipsilateral autonomic symptoms. Attack have a circadian and a often seasonal pattern with a pattern of remission that can last 1 to 2 years, episodic pattern. Each cluster headache is characterized by the severe or very severe unilateral pain, orbital, supraorbital, and a temporal area, which can reach the 50 to 180 minutes. It must be accompanied by the either ipsilateral autonomic symptoms like conjunctival injection or lacrimation, nasal congestion, eyelid edema, forehead and facial swelling, meiosis or ptosis, and restlessness is also occur. Cluster headache tend to occur in the series of week to month called the cluster period. Epidemiology. Cluster headache is the most common type of cluster headache tend to affect a man more than the woman. Man over to woman ratio is a 4:3. It's all over show the lifetime prevalence 120 for 1 lakh people, which tend to remain stable and independent of the region of the study. Cluster headache may have some genetic influence. First degree relatives 18 times more likely to diagnose with cluster headache. The most inheritance remain unclear, but both autosomal dominant and autosomal recessive pattern has been observed various families. Sign and symptoms of the cluster headache. Cluster headache is symptoms affect the face in the ipsilateral side. The cluster headache is strike quickly. There is usually no warning sign, but some patient might first have a migraine-like nausea and aura, extreme sharp and stabbing pain, usually in the behind or around the eye. The pain can spread to the area like the face, head and neck, and lot of tear called the lacrimation. Redness of the eye, stuffy and running nose is seen, forehead and facial swelling, skin color changes on other side of the face that hurt, dropping eyelid, ptosis called, because of the pain is the cluster headache can be so bad. Those who have one are likely a rock back pain. Treatment of the cluster headache. There is the three arm of the treatment of the cluster headache, like acute, preventative, and bridging therapy. In acute therapy, we give the patient the oxygen has been well established as the acute treatment of the cluster headache. Then sumatriptans, octreotide, zolmetriptans. Their adverse effects are seen is paresthesia, flushing, tingling, chest pain, and neck rigidity is also seen. Preventative therapy. The goal of the preventative therapy is reduce the frequency and intensity of the attack by eventually a shortening and the duration of the cluster period. It should be started at the same time that mode of the therapy mentioned previously. After the attack free period of 2 weeks, it should be a taper down after the 2 weeks. In preventative therapy, we give the verampamil, lithium, deep brain stimulation. And after the preventative therapy, we give the bridging therapy of the patient. Bridging therapy can be considered as a therapy used for a temporary period of the time with purpose rapidly reduce the frequently cluster headache attack. We give steroid as the commonly using the bridging therapy due to their ease of use. Side effects of the steroid are seen, especially long-term repeated use, which include weight loss, endocrine dysfunction or abnormality, and avascular necrosis. And another bridging therapy is a suboccipital nerve block injection with steroid. Thank you.
Thank you, Dr. Jigar.